Hello, pharmacology friends, Dr. Bratt, and here's another chat with Bratt, and this one is about drugs to treat diabetes. It's going to be broken up into several pieces, so please go through each of these presentations and you'll get a whole picture about drugs to treat diabetes. So let's get started with the first presentation. So when we're talking about drugs to treat diabetes, we want to be thinking about what happens with the glucose homeostasis. And as you can see in this diagram, this is what's going on in our body on a normal basis, is that we are constantly trying to maintain a stable blood glucose level. And all these mechanisms are taking place. So if you think about it, if for some reason that our blood sugar is basically going up, what's going to happen is that the body's going to be triggered to release insulin, because insulin's job is to take the glucose out of the bloodstream and put it into the cells, into the muscles, and wherever it's needed. And what's not needed, it goes to the liver and it's stored for future use. So what happens in that process, blood sugar goes up and you're going to see then the stabilization of glucose levels. Now, on the flip side, if we have falling blood sugar, what's going to happen is the opposite's going to happen. So we've got to liberate glucose. So what it's going to happen here is that it's going to cause the pancreas to basically secrete glucagon. And glucagon is a storage form of glucose, and that's going to stimulate the liver to release that. And it's going to bring the blood sugar back up to normal. And that's important. So this mechanism is going on at all times to maintain homeostasis and maintain a stable glucose level. So let's meet our first patient. So this is Mrs. Waller. She's 35 years old. She presents to the ED, and in taking a health history, we found out that she has not been eating well. She's been having a lot of urine output. She's feeling hungry all the time. She doesn't feel like herself. And when we take her glucose levels, we find that she's very hyperglycemic. So all of a sudden, she becomes very unresponsive. And of course, we get very concerned. So let's kind of figure out what's going on with her. So with Mrs. Waller, she obviously has type 1 diabetes based on her history and on her blood studies that we've identified the diagnosis of type 1 diabetes. And with type 1 diabetes, what happens, you can see in this diagram, is that when we eat, we take in our food and it converts food to glucose. That glucose then gets into the bloodstream, which then, of course, generates blood glucose. And then what happens? It sends a signal to the pancreas. The pancreas does its thing to basically release insulin. But in her case, it doesn't happen. The pancreas is not doing its job to release insulin because it really doesn't have that ability to make may not have the ability to make any insulin or to make very little insulin. So what happens that the patient becomes very hyperglycemic because there's no way to take that sugar, that glucose out of the bloodstream and put it into the cells. So what happens, you've got all this glucose in the blood cells, in the blood vessels, and you've got this glucose levels building up. So that needs to be treated. So if you remember back from patho, what happens with insulin? Insulin, plain and simple, is really simple in the fact that it is like a key. Insulin is the key that opens up cells that allows glucose to go into the cells. We don't want glucose just floating around in the bloodstream. We want glucose to going into the cells where it's going to basically feed the body and be liberated when we need it. So that's what it is. So with Mrs. Waller, there's not this key to let the insulin go into the cells so that glucose keeps circulating in the blood vessels and it's not getting to the target organs, and you're seeing all kinds of signs and symptoms. So this is what diabetes is, plain and simple, is that it's deficient insulin production. So we don't have enough insulin, so we don't have that key that lets the glucose go into the cells, doesn't let it go into the muscles, and we get this hyperglycemia. And with that, it comes, we can't digest and use our carbohydrates, our fats, our proteins. And if this proceeds, it's going to create lots of problems long term. So what happens then is when we don't have sufficient insulin, is that blood sugar is going to go up. That's a hallmark sign and symptom of diabetes. We've got this sugar then that spills into the urine, and that's what's called glycosuria. And because we're losing excessive urine, it pulls off that sugar in the urine, makes urine production increase. So then the individual becomes very thirsty, which causes polydipsia, increased hunger because we can't be using our carbohydrates because we can't break down those sugars and get them into our cells. So we start using fats for energy because we can't use our glucose. And then we have problems with ketosis. And if that continues, we might have problems with ketoacidosis. And acidosis can occur also when the liver is not able to process these waste products that are going on because our metabolism is off kilter because of the fact that we don't have insulin. So this is a dangerous complication of hyperglycemia. So the patient can have fruity breath, and that's one of the hallmarks. It sounds, if you smell, get up close to that patient, you can smell that like they're chewing juicy fruit gum. Dehydration, again, that's because we're losing lots of fluid in the urine, and what happens, the body becomes very acidic. And you know what the body's normal response to metabolic acidosis is to try and blow off carbon dioxide to decrease the acidity in the bloodstream. And this is how the individual presents. And in Mrs. Waller's situation, she went into ketoacidosis and she became unconscious and unresponsive. So again, this is the mechanism of ketoacidosis. We can't get glucose into the cells, okay? Again, so the body is burning up fat for fuel. So if you know anybody that's on this ketogenic diet, that's exactly what's happening. Instead of using carbohydrates for energy, in a ketogenic diet, you start burning ketones, those fat stores, to basically provide energy for the body. And a byproduct of that is this fruity breath and this ketosis that goes on. So again, what happens is this metabolic acidosis, and the way the body deals with that is that blowing off that CO2. And that is called that Kussmaul's respiration. And it's the body's attempt, it's a physiological response to deal with the situation of acidosis. So how are we going to treat Mrs. Waller? We're going to treat her with IV fluids because she's dehydrated, because she's been losing fluid from the polyuria. We're going to then treat her with insulin. She's not producing insulin on her own, so we have to give her exogenous insulin. So when we think about that, we have to kind of think about what happens in the body under normal circumstances. Because when you talk about drugs to treat diabetes, what we need to be thinking about is these drugs to treat diabetes is trying to replicate the body's normal mechanisms. So if you look at this diagram, you can see that there are peaks and valleys with our insulin production, which basically correlates with meal times. Throughout the course of a day, as you and I eat, so you eat breakfast, and you can see here on this is that on the bottom diagram is that you can see right here is that the glucose levels go up because we just ate, and that's normal. And so consequently, what happens normally in our body after we eat breakfast, our insulin level production goes up, and it goes up to address that glucose load from our breakfast. Then after breakfast, our glucose levels, as we digest those carbohydrates and other substances that we're eating, our glucose levels go back down to a baseline level, and then it's going to peak again when we eat again. So again, if we eat at lunchtime, the glucose levels are going to go up and your insulin production goes up. And then as we start to digest our food, our insulin levels are going to go down as our glucose levels go down. So this goes on with our meals. When we eat, we need insulin to drive those carbohydrates into the cells. And the body, if it's healthy, doesn't have diabetes, you're going to see these peaks and valleys of insulin production. And this is important. Another important aspect of this diagram is you can see that over the course of the day, we have what we call glucose levels, our insulin levels going up and down, just like the glucose levels as we eat. But all the time, we have a baseline level of glucose in our body, which means we also have a baseline level of insulin in our body. And this is important because our drugs are going to try and mimic this. So as we try and do insulin therapy or therapy with our oral medications, we always have to keep in mind of what's happening physiologically what we want the body to responding to when we are trying to maintain an optimum blood glucose level. So keep that in mind as we talk about drugs. So again, this just shows you what happens with meals and with blood glucose and insulin. Again, when we eat carbs, our blood glucose is going to go up and our insulin levels is going to go up correspondingly. So what happens in diabetes is you can see this very erratic pattern where they've got these spikes in blood sugar, and then they have these lows where they can have lows. And what we're trying to do here is we are trying to moderate this so these patients have a more normal pattern of glucose. So again, just to recap, so the functions of insulin is to help that insulin to go into the muscle tissues and into the fat cells. It helps us basically to metabolize our carbohydrates and provide us energy to engage in daily life. It helps to get those amino acids moving into the cells so they can make proteins. It absolutely helps us with fat metabolism and synthesis. It also stimulates our cells to take up potassium. Those are just all the normal functions of insulin. So, Mrs. Waller has type 1 diabetes. And so stay tuned for presentation number 2, and we're going to talk a little bit about how we're going to treat Mrs. Waller in her type 2 diabetes. See you in a moment.